Great. Well, thank you, and good morning, everyone. It's so wonderful to be here at the Drop-In Centre here in Calgary, one of the important institutions here in Calgary in the homeless serving sector, the homeless serving system of care. And so much more than just being an emergency center. Here they provide health services, housing supports, employment training, and so I'm so pleased to be here at the Drop-In Centre for this announcement. The COVID-19 pandemic has been with us for 10 long months, but at last we are at a turning point. This week we're seeing the first signs of a downtrend in the cases that we confirm each day. And we've started to vaccinate healthcare workers. Now, it's only a small number so far. I think AHS was expecting to give about 400 staff their first shots yesterday. Vaccination will turn the tide of the pandemic. It's underway, and we'll stick at it till the pandemic is behind us. It's good news, and we need some of that right now. But we have to be clear, the toughest weeks for our hospitals and our healthcare providers are still ahead of us. There are too many very sick people in our hospitals, and the numbers are going to keep going up for at least another couple of weeks because of the high numbers of new infections that we have been reporting. Now, we need to bend the curve down sharply and keep it down, and that means people have to follow the restrictions that are in place. And it's going to be a tough Christmas. I'm feeling it just like other people are. It's hard on my kids not to see their friends. It's hard on them not to see their grandparents. For me, not to see my parents and my siblings. And it's hard on all of us that we can't visit with our families at this time of year. Now, if you're frustrated at the restrictions, I'm with you. But let's also think about what Christmas is going to be like for the people working in our hospitals and for their patients and for the families of those patients. For a start, as of yesterday, there were about 190 patients in the general adult ICUs, when the normal capacity is 140. At full capacity, which is supposed to be an exception. And the staff know that number is going higher. AHS has plans in place to expand to as many as 425 of those spaces. But that means disrupting the system on a scale that we do not want to see and that we cannot sustain for a very long period of time. Now, on top of caring for all of those patients in ICU, and hundreds more in regular medicine units, I should say, the staff and the physicians are doing their very best to substitute for loved ones who can't visit. They're saying goodbye to too many patients who are spending their last days alone, and they're making too many of those phone calls that they dread. The numbers have come down, and we can't wait for vaccinations to make that happen. So as we head towards Christmas, I want to say to everyone in the healthcare system, thank you for being there for us. And I want to add a word about a group we don't talk enough about, medical residents. Now, I had a letter this week from Dr. Matt Menon, a trauma surgeon at the U of A hospital. And I want to read a little bit of this letter because he gave me permission to do so. And in Dr. Menon's words, he said, quote, "Since the pandemic began, resident physicians in Alberta have been continuously putting themselves in harm's way to care for patients. These young physicians have shown tremendous courage, resilience, and sacrifice. The cohort who began working as doctors this summer, many of them in their 20s and early 30s, began seeing patients at the height of the pandemic. They provide an immense amount of medical care in Alberta, and their contributions deserve more recognition." And Matt, I can't agree with you more. Thank you to our medical residents and everyone in our hospitals. I'm sorry that that was a bit of a detour, but it needed to be said today. And now I want to turn to the announcement that I'm here today at the Drop-In Centre to make. From the start of the pandemic, one of our strengths has been testing. To date, AHS and Alberta Precision Labs have completed more than 2.5 million tests on more than 1.5 million people here in Alberta. And I'd like to thank the staff who are working hard in our assessment centres, in our labs that are processing the samples as fast as they can. A few weeks ago, I announced the start of a rapid testing pilot program here in Alberta. Rapid tests allow us to identify cases of COVID-19 faster, so that the infected person can isolate sooner and reduce the risk that they'll infect other people. Now, since we started rapid testing, 76 positive cases were notified within just a few hours. We've already expanded the pilot in Edmonton and Calgary to the isolation center in Edmonton and here at the drop-in center in Calgary. They're using rapid tests for homeless people where the spread of COVID-19 is especially difficult to control. And the tests are working well, so I'm pleased to announce that we're expanding rapid testing in Alberta a lot further. Starting tomorrow, we'll be piloting rapid testing in long-term care and designated supportive living facilities, or DSL facilities. Mobile units will be deployed to bring the test to facilities with outbreaks and the potential for outbreaks. And we'll start at facilities in the Edmonton zone and then Calgary and then across the province. Testing will focus on residents who are showing symptoms. We'll be using the Abbott PanBio antigen test, which is very accurate when it's used on people who have had symptoms for less than 7 days. It means that we can identify positive cases within hours. We'll also be adding rapid point-of-care testing at 25 rural hospitals in the north, central, and south zones through the remainder of December and early January. So this is rural hospitals from Cardston to Pincher Creek, from Cold Lake, St. Paul, and Peace River. And these 25 sites, all 25 of them, these new sites were chosen based on their location in rural and remote communities, based on transport time to a lab that processes rapid tests, the volume of tests required, and the population's need for them. The expansion of rapid testing means that we can notify healthcare teams sooner to prioritize those who are still infectious. And it will also free up capacity and reduce turnaround times for the PCR tests that our labs will continue to provide across the province. Now, this is an exciting development. We're continuing to press forward on every aspect of our response to the pandemic. This is from testing to vaccination. And as I said at the outset, these numbers are good news, but they're the start of the vaccinations is even better news for us. But we have to bend the curve down, and that means we have to stick at it. We have to stick with following the public health measures that are in place. And so thank you very much for joining us this morning. I'll now invite Dr. Will Stokes from AHS, who by the way, Dr. Stokes is on call right now, so thank you to him for spending his time with us for this important announcement and for the important work that he does for patients throughout the province. So I'll now invite Dr. Stokes to come to provide more information about the rapid testing program.
Thank you, Minister Shandro, and thank you to Sandra and your team at the Calgary Drop-In Centre for hosting us today. Over the last few months, the medical teams at Alberta Precision Laboratories have undertaken significant work to evaluate the effectiveness of these two rapid point-of-care tests that we received, one called the PanBio, and the one being used at the Drop-In Centre here is the ID Now. This work that we've done is important to determine how effective these tests are compared to the tests we currently use at our provincial labs today, which are considered these PCR tests, considered the gold standard for testing COVID-19 in large populations. What we found with this work is that these rapid tests are effective in identifying positive COVID-19 cases, especially in people with symptoms and signs of COVID-19 infection. This validation work is being used to implement these rapid point-of-care tests across the province and is actually being shared with other provinces to help them determine the best use of these rapid tests as well. Speeding up the identification of positive COVID-19 cases using these rapid tests is important to contain the spread of virus in our communities. It will also help alleviate some of the pressures that we face at the provincial laboratory with these positive samples. And this will have even more importance as we roll out more and more of these tests across the province. Introducing rapid COVID tests, such as the ID Now, at places that have the highest risk populations for outbreaks, including the Calgary Drop-In Centre and the Edmonton's isolation facility, is a top priority because we know it will have an immediate impact in protecting the health of people who are at highest risk for infection and for those who are hard to reach with our current testing that we do at the provincial laboratories. Please keep in mind it is not as simple as handing these devices out to various people in areas. In order to work effectively, they need to be used by trained staff. And although these tests can give results within minutes, there are many other factors to consider when we roll these out to the different areas. For instance, we need to make sure the proper swabbing of patients occurs, the handling of patient samples, the operation of the testing equipment, as well as the proper recording, notification, and follow-up of test results to patients. The other priority that we are considering for deploying these point-of-care tests is at long-term care and designated support living facilities around the province. Since day one, we have been coming up with ideas to get these point-of-care tests out to the various nursing homes across the province, which are very many. And we have come up with an innovative solution to help with this. Starting tomorrow in Edmonton, we will be rolling out the first mobile COVID-19 testing unit that we have developed with support from private sector partners. These mobile testing units will allow us to screen staff and residents of long-term care facilities and multiple other sites every day, so we can quickly identify and contain potential outbreaks in our highest risk populations. Work is underway to expand the use of mobile testing in Calgary, Central Zone, and other communities in the week ahead. For me personally, it has been incredibly exciting and rewarding to be part of the team that has built a very strong and robust COVID-19 testing program here at Alberta Precision Laboratories. We have had to move fast while maintaining the scientific rigor that is required to ensure we are successful in the long term and never losing sight of the safety of our patients and staff. Thank you again, and I appreciate the opportunity to talk more about our work at Alberta Precision Laboratories. And I'll hand it over to Sandra. Thank you.
Thank you, Dr. Stokes. Good morning. It is a privilege to be here and have an opportunity to say a few words. What a difference a year makes. This time last year, we were enjoying similar weather, preparing for a cold snap, and looking forward to the holidays. A year later, we have a much more complex situation to live and work in. But with the COVID-19 pandemic has demonstrated that we are stronger when we work together. Since March, the Calgary Drop-In Centre has worked closely with the Government of Alberta, Alberta Health Services, the city, and several partner agencies across the homeless serving sector of care to ensure our community's homeless population has uninterrupted access to food, shelter, health services, and housing supports. Having point-of-care rapid COVID-19 testing on site will be incredibly valuable for us to monitor the health of our clients, as well as protect our staff and the public as we manage during this pandemic. The homeless serving sector, including the drop-in centre, have experienced outbreaks, no differently than any other congregate or close community settings across the country. The opportunity to access the rapid testing is another powerful tool in our toolkit of care to help our clients and our staff. Thank you, Minister Shandro, for your and Alberta Health's continued support in protecting and recognizing the health needs of our homeless community during the pandemic. We are stronger together, and our homeless serving sector partnership with the government has made a difference. Rapid testing at the Calgary Drop-In Centre will mean that we can even better support clients who who are symptomatic or close contacts and help them to isolate more quickly. I'm optimistic that this rapid testing will help us reduce the spread of this vulnerable population group. Like other frontline health and social service organizations, our health and safety protocols are essential to keep our shelter staff safe and accessible to as many Calgarians as possible. Thank you, and I would like to now hand it back to welcome Minister Shandro back to the podium.
Thank you. We're now going to go to the phone line. For the first couple, we have a few people on the line, so if you could limit your question to one and then one follow-up, that would be great. Operator, can you please put through the first question?
Our first question comes from Bill Fortier of CTV News. Your line is open.
Hey, Bill.
Hi. Hey, guys. The Dr. Stokes, I believe the name was, said that these tests, these rapid tests, are effective, especially in people with symptoms. So I'm wondering how effective they are in people without symptoms, because we know a lot of people don't have symptoms, especially in the onset of this, and then can still infect other people. And if they are not effective in people without symptoms compared to the tests we're using now, how concerning is that?
Yeah, and maybe I'll ask Dr. Stokes to supplement this, but that has been some of the frustrating parts of I think for people as we've learned about rapid tests and we've been deploying rapid tests, I think there's been a lot of misinformation of what rapid tests could and can't do. So rapid tests are fantastic when somebody is symptomatic, especially symptomatic in the last 7 days. If there's a positive test when somebody is symptomatic, then we know that that's a positive, and we know that that's correct. But if somebody's asymptomatic, that doesn't really help us. They can test negative and still be positive. It doesn't really help us diagnose when somebody's asymptomatic. So it doesn't really necessarily help if somebody tests negative from a rapid test. If they're asymptomatic, that doesn't stop them from still having to self-isolate. And so that's been the frustrating part for a lot of people who have been hoping for rapid tests to perhaps been a solution to the self-isolation requirements for somebody if they are a close contact or if they have symptoms even, actually. But Dr. Stokes, I don't know if I got any of that wrong, if you want to supplement any of that answer as well? Or no? Sure. Sure.
Hi, thanks. Great question. It's difficult to get a lot of data out of the asymptomatic people because we know there's a lower prevalence of COVID-19 when you start testing those people. So you need to test, say, 1,000 people to get enough data to confirm how well the test works in that population. If we target a population that has signs and symptoms, we're able to capture a lot more data faster. And that's our goal, is to try and get these out as fast as possible. We are exploring the possibilities of asymptomatic testing, but we started first with people at highest risk of COVID-19 and also to make sure we get them out as fast as possible.
Bill, did you have another question?
That's it for me. Thank you.
Okay, thank you. Operator, can you put through the next caller?
Our next question comes from Dean Bennett of the Canadian Press. Your line is open.
Thanks. Good morning. Questions for the Minister. Minister, could you flesh out, please, what Dr. Hinshaw announced yesterday in terms of the field hospital in the Butterdome? I'm looking, could you address specifically, do you expect it's going to be needed? I know it's a contingency now. What metrics would you use for it to kick in? I assume it would be hospitalizations. Who would use it? Is it Edmonton and Northern Alberta? Would this be for non-COVID patients or other patients or mild to medium patients with mild to medium issues? And when do you expect to be operational? Sorry, too many questions, so little time.
No, that's okay. Thanks, Dean. Good question. And so this is the same news as from weeks ago. This is the tent that was contracted through the Red Cross. This is not part of the current forecast and the current plans that AHS has to be able to get to 2,250 COVID-dedicated beds. throughout the system. And so this is a contingency plan that if we ever did need to go above the 2,250 dedicated beds to COVID patients. Now, whether folks who would be needed, if we needed that contingency plan, what type of patient would be in there, I would leave that for AHS to be able to make those decisions. That would probably be decided at that time. Some of it also depends on the extent to which we still try to continue to keep our surgical capacity as high as we can in Edmonton zone, knowing that we have had to make some decisions, tough decisions to postpone some surgeries, thankfully not as much as other jurisdictions in Canada have. We're going to continue to make sure that everybody who needs critical care gets that care that they need, or everybody who's critically ill gets the care that they need. We'll continue to make sure that not only are we making sure we have capacity for our current forecasting, but of course we want to take steps to develop contingency plans as well, which is only prudent planning. Thank you, Dean. A follow-up, Dean?
Yes, just quickly, I know that these Red Cross things actually come with staff as well, and staff's an issue for you. Do you know whether there'll be Red Cross staffers in this? And can you just update me on Peter Lougheed? What's it being used for right now? Non-COVID patients, and how many, and is it close to capacity?
No, from my understanding, from what I've been advised by AHS, it wouldn't include staff from Red Cross at this time. I know we are using Red Cross in other ways, like their comfort care aid training program and stuff like that, but not for the field tent that we've contracted with them. When it comes to the Peter Lougheed, I would actually defer that question to AHS to answer what type of patients are in there and how many are in there as of today, just because I haven't briefed on that this morning. So I'll pass that question off to them if you don't mind, Dean.
Operator, can you please put through the next question?
Our next question comes from Catherine Grigowski of Alberta Today. Your line is open.
Hey, Catherine.
Good morning. Thanks for taking my question. I'm not sure if this is best to the minister or to Dr. Stokes, but part of the international travel pilot was a rapid test that allowed people to not have to quarantine so long as they got a negative result. But if they're not so accurate in asymptomatic people, does that change anything with the international travel pilot for testing?
No, it doesn't change anything with the travel pilot, but I think that the travel pilot, the point of that and why we were very happy to work with the federal government on getting that across the line was because rather than letting somebody just tell us that they were going to self-isolate, and for us hoping that they do self-isolate at home for the required period of time, that we actually did start testing people. And there were some folks who on that first test were determined to be positive, so we could get them isolated right away. And a small number who ended up being positive at that second test. So it also helps us being able to get more data on how we might be able to continue to respond to the pandemic and continue to look at how how long the isolation periods need to be, and whether we can continue to test in different ways for people who need that self-isolation. So my understanding is there doesn't have to be any changes right now with the travel pilot, with these the rapid tests that are deployed there.
Did you have?
And follow up if I may. You also mentioned that there's a private sector partnership in this expansion. What company is working with the government, and how much is being put towards that portion of it?
For the mobile testing, I think. I may have to defer that question to HS if you don't mind. I don't remember the name off the top of my head. It was an acronym, so I apologize to the vendor for me not remembering their name. But that, if you don't mind, Catherine, if I put that question to HS. Unless, Dr. Stokes, do you know off the top of your head?
For the mobile testing
Yeah.
centers, it's ASO and Calgary.
ASO and it was and Calgary.
We've got a number of people now on the line, so we're going to have to limit it to one question. Operator, can you please put through the next caller?
Our next question comes from Chris Epp of CTV. Your line is open.
Thank you. I'll sort of roll these two questions into one. First, just a point of clarification. Am I understanding that these rapid tests are only used on symptomatic people at sites where there could be outbreaks? So, for example, if someone's likely been exposed in a long-term care home or somewhere else, but isn't symptomatic, do they not get a test? Maybe you can clarify that. And just as part of that, I'm also wondering, as we look forward to vaccines in the coming months, would the government take those who've confirmed positive cases, the 40, 50,000, whatever it is, and say people who've had COVID for sure go to the back of the line for a vaccine, given that it's likely at least that they'd have more immunity to the virus? Thank you.
Sure. And do you mind in the back, can we turn up the volumes a little bit? And do you mind repeating your first question? I did get the second question about vaccines, but do you mind repeating your question about the rapid tests and the asymptomatic?
Yeah, I'm just trying to clarify that if rapid testing, a unit is deployed to, let's say, a long-term care home where there's an outbreak, is it only people who've been, who are symptomatic that will get tested, given that these are for symptomatic people, or someone who's not showing symptoms but lives in a long-term care home where someone is infected, would they also get the test?
So my understanding is that the point of the rapid care tests, whether it's in a long-term care facility or DSL or in a rural hospital, is for us to be able to help somebody who is symptomatic, find out that they're positive, get them and their close contacts isolating right away. So that's the point of it. And quite frankly, it wouldn't help somebody who is asymptomatic, whether they're in continuing care or not, to avoid self-isolation if they have a negative test. So my understanding from AHS is that there would be no use of the rapid the rapid tests on asymptomatic patients, or residents, I should say, if it's a long-term care facility. Oh, sorry, vaccinations. No, so at this time, your question was about vaccinations and whether people who have already had COVID would be put at the back of the line. Look, I think we're still learning to the extent to which antibodies can stay inside a person's body. And so, no, we're not making those decisions at this time, especially in phase one. We want to make sure that people who are at the highest risk of really severe outcomes, death, hospitalization, and so that's residents of continuing care, seniors who are 75 and over, and as well as our healthcare workers who are the highest risk to expose them, that those folks, whether they had COVID or not, are getting it, especially in phase one. So I'll leave it for that to be something that might be considered by the Chief Medical Officer of Health, Dr. Hinshaw, as she comes forward with recommendations for us with phase two. But my understanding is just with what we don't know about how long antibodies might stay in someone's body, that there's no plans at this time to not give or put somebody at the back of the line for COVID or for vaccinations because they had COVID already.
We have time for a couple of more questions. Operator, please put through the next one.
Our next question comes from James Keller of the Globe and Mail. Your line is open.
I have another question about this Red Cross site in Edmonton. Earlier, a few weeks ago, you suggested this was all just essentially phone calls from AHS to talk about potential logistics, and there were no plans to do this. Now it's going up, and you say there's no plans to use it. So did something change since your earlier comments that really seemed to downplay the idea that these Red Cross facilities would need to be set up? And are there other Red Cross tents that are, even if it's just a contingency, in the process of being set up or about to be set up?
No, it's nothing's changed. AHS entered into the discussions, knowing that if you want to secure a tent, same way that we had secured the Sprung tent that was donated to AHS by Sprung Structures, that they would have to enter into that contract. It's been entered into. They're installing it, same as the Sprung structure was installed. But no, as I said earlier, there's nothing that's changed in our forecasts. And it's not part of, as I've said many times, of the 2,250 dedicated COVID patients or COVID beds in AHS that AHS is going to be dedicating.
Operator, please put through the next caller.
Our next question comes from Francois Joly of Radio Canada. Your line is open.
Hi, good morning, Minister. Yesterday we saw Minister Madhu post a photo on Twitter showing himself, also Minister Allard and Premier Kenney in a meeting. All three of them were not wearing masks. Why not wear a mask in meeting? And is that sending the right kind of message when the government and AHS is actively trying to convince Albertans to wear masks?
So I don't know the situation, I have to admit, off the top of my head. So, but obviously, all of my colleagues, we are wearing masks as often as we can. So I don't know the circumstances and why masks might have not been in that photograph. As I'm not wearing one right here in front of the microphone, from the advice that we've received from the Chief Medical Officer of Health, when we're here speaking at a podium, it's different than a workstation as it's been defined in the public health measures and the public health restrictions. But that might be a question I defer to Dr. Hinshaw.
Operator, please put through the last question.
Our final question comes from Stephanie Rousseau of Radio Canada. Your line is open.
Hi there. I have a follow-up about the butter dome. I was just wondering, why not set it up right now so it can be used and then so that the government would be able to bring back surgeries maybe in Edmonton? Why is that not a possibility right now?
My understanding is from AHS, now that they have it, they have the plans to put in the butter dome. I'll leave it for AHS to decide if and when something is installed. I mean, AHS, I think, especially the clinicians that are in AHS will know if and when something should be installed and what patients should be put where. That's not a decision that a politician should be involved in. But I'll just point out that, you know, it was weeks ago when we started with these contingency plans, and the media were incredibly upset with me because we would dare to have contingency plans. Of course, we were making prudent plans to be able to respond to the pandemic, spending $2 billion in response to the pandemic, making sure that AHS has all the resources that they need. Workforce capacity, especially in our testing system, especially in our acute care facilities, to be able to respond to the pandemic, $170 million to our continuing care operators to make sure that they have the PPE and workforce capacity they have. And we're going to continue to make sure that our continuing care operators and AHS have all the resources that they need to be able to make these decisions, to do this prudent planning, and to be able to make sure that everybody in this province gets the care that they need. Thank you.
Thank you, everyone. That's the end of today's event. Thank you for joining us.
Thank you.